I present on stemless total shoulder using a large LTO technique. My name is Brian Badman. You may visit my website at Indie Shoulder for more information. This is a case of a 66-year-old right-hand dominant male with progressive right shoulder pain. Functional scores and motion both compromised, with radiographs consistent of an A1 glenoid. And this is my approach. Incision is a standard deltopectoral approach overlying the coracoid process with meticulous hemostasis. Next, the spaces are developed with release of the subcoracoid space and palpation of the axillary nerve for identification, and then continuing into a subdeltoid release with release all the way down to the deltoid tuberosity prior to any retractor placement. Adequate releases are verified when an upside down U can be traced from subcoracoid into subacromial and down into subdeltoid space without any further adhesions. This is now verification of complete release manually. A brown retractor is placed to retract the deltoid. A blunt Homan is then placed below the conjoint tendon and provisionally clamped to the drapes for initial exposure. The bicep tendon is localized within the groove and released through the rotator interval to the level of the glenoid with Metzenbaum scissors. The bicep tendon is next in situ tenedized to the upper border of the pectoralis with a number 2 suture of choice. Next, the tendon is released, and any stump of the tendon will be retrieved later on exposure of the glenoid. The subscapularis is now tagged with a number 2 suture in a Krakow fashion to facilitate further releases and exposure of the glenoid. A bovie is used to clear off all soft tissue within the groove prior to the osteotomy technique. The osteotomy technique is facilitated with a TPS saw and a 2cm blade as shown here. I begin by aiming the blade at the deepest portion of the groove, pointing towards the distal third of the coracoid process in terms of adequate depth of the fragment. You typically want to begin proximal, bearing the depth of the blade as deep as possible, and then continuing along centrally. As the osteotomy is continued further distally, you do not want to bury the blade quite as deep, and you want to curve it out to avoid fracturing or cutting into the calcar segment and injuring potentially the axillary nerve. You want to make sure that a complete release from proximal to distal is verified prior to placement of the osteotome. At this point, the osteotomy is completed then with a 3/4 inch osteotome, making sure that the osteotome is impacted to the level of the subchondral bone of the humeral head prior to cracking it. Otherwise, this can prematurely break the fragment. I then lever it as such and reflect the fragment and residual articular segment towards us, which can then be further released with the TPS blade. This allows for creation of a nice fragment that will key in at the end of the surgery, much like a puzzle piece fragment. Care should be made to protect the tendon with release here. I'll then bevel off the residual ridge to smooth this down. A rongeur can also be helpful. Next is humeral prep. Once the articular segment can be visualized through the osteotomy, the Hohmann is repositioned now into the joint, and typically by gently externally rotating and extending the arm, the soft tissue will oftentimes release off the inferior humerus. A second Hohmann can be positioned to help facilitate further releases, and oftentimes a bovie is helpful now to release posteriorly to 3 o'clock, referencing a right shoulder, and 9 o'clock referencing a left shoulder. This is an important portion of the release to allow for next steps and exposure to the glenoid. A third Hohmann can be placed to reflect the rotator cuff insertion prior to the head cut. If osteophytes are present, now is the time to remove them with an osteotome or a rongeur to replicate the Gothic arch. The cut guide can now be placed in an extramedullary fashion with a 30-degree retroverted cut referencing the transepicondylar axis. 2 pins are utilized to prevent any varus or valgus malpositioning of the extramedullary guide. Proper cut level is now made right at the cuff insertion. A saw blade is now used in a meticulous fashion with care to protect the rotator cuff insertion and to cut down and away from the rotator cuff. Care should also be made to make sure the blade remains flat along the cut guide and to not lift this up, as this can change the version of your head cut. Next, the cut block is removed, and the cut surface will now be sized. It's important to reference the posterior superior head segment, as positioning the trial there will allow for proper positioning of the head elsewhere. If there is any discrepancy between head sizes, oftentimes if you're in between sizes, it is best to go with a smaller sized head option, as any residual bone inferiorly could be residual osteophyte that can now be removed with a rongeur. A centering pin is now made to establish the centering point to also allow for next steps of reaming. This pin should be in the direct center of the circle that has been made. The inset reamer is now utilized, which allows for inset of the eventual body of the stemless implant. I will now select the punch. Generally, a size 2 is appropriate for 90% of patients and anatomy. This is impacted down. The fins can be rotated to avoid the LTO segment. Generally, the superior fin is at 12 o'clock, but it can be rotated to, again, accommodate the osteotomy. It is now impacted down, and the trial body will be left in place for eventual trialing with the head. The centering pin will now be removed. As you can see, the body is well secured even with a large LTO technique. We'll now go to the glenoid. Glenoid exposure begins by placement of a Fukuda retractor posteriorly by slightly abducting the arm. This can help detension the deltoid. Tractioning of the subscapularis can now allow for palpation of the axillary nerve. This allows for placement of a blunt Hohmann over the top of the nerve to allow for subsequent release of the inferior capsule. Again, by tractioning the subscapularis superiorly, the lower border of the subscap is identified and release is continued through the inferior capsule to the level of the inferior glenoid at 6 o'clock. Bovie is helpful in this case to allow for identification of any close proximity to the nerve. The anterior glenoid is now released sharply between the interval of the capsule and the labrum, with the release carried up all the way to the base of the coracoid. Any residual anterior IJHL can subsequently be released. An anterior Bankart retractor at this point can now be placed along the anterior neck of the glenoid and clamped to the drape. Any residual labrum inferiorly and anteriorly are now removed, extending superiorly into the stump of the bicep. In an anatomic shoulder, oftentimes the posterior IJHL will be preserved. However, in a reverse, a complete 360-degree release should be carried out. Finally, a pointed Homan is placed at the 1130 position, and this completes the retractor placement. The glenoid surface is now palpated and any relative version is noted. Trialing is now performed. Again, if in between sizes, typically I go with the smaller diameter size. A center hole is now marked and drilled to allow for placement of the reamer. Reaming is usually conducted with the same diameter as estimated for the final implant. Care should be made as the reamer is set that no impingement along any of the retractors takes place to avoid for fracturing of the glenoid. Any high side correction can now be performed. Once again, care should be made to protect and preserve the subchondral plate and also palpating for any residual ridges to confirm a concentric ream. Once the ream is concentric, next the peg guide is positioned with the superior hole typically drilled first. A placement peg can be then positioned in the superior hole to prevent rotation while drilling of the remaining holes. Trialing is usually carried out after all holes have been placed, and the holes are next irrigated with pulse lavage. At this point, the cement is typically mixed and the implant is opened. The holes are then individually dried with either suction or gauze. And using a split tip 10 cc syringe, now each of the holes are cemented and manually pressurized. All holes do receive cement. This is a self-pressurizing glenoid that does further interdigitate the cement while placement of the actual implant. The implant is then passed to the field and impacted down. The pegs are slightly larger than the holes that were drilled, again because of its self-pressurizing design, and it is fully impacted down with an impactor. Any residual free cement around the implant will then be removed, and final verification is made. We will then proceed to the humerus. The Fukuda retractor is carefully removed with care to protect the glenoid component, and the brown deltoid retractors and other retractors are now repositioned to allow for visualization of the proximal cut surface of the humerus. The body is inspected to make sure it is still properly positioned, and final retractors are placed. At this point, the head that had been previously selected is now screwed into the body of the trial. Any residual bone, specifically posterior inferiorly at this point, can now be removed with a rongeur, again prior to final trialing. Once all bone is removed, retractors are taken out and final trialing is performed. Proper balancing is achieved with 50% posterior translation with a good bounce back, verification of forward flexion greater than 120 degrees, internal and external rotation, and confirmation that the osteotomy reduces into the bed of the osteotomy site. Good motion is confirmed and retractors are now replaced with the trowels removed. The implant can be removed all in one. Cut surface is irrigated. Next, the LTO repair is facilitated by placing 3 drill holes with a 2/0 drill bit, with one began superiorly, one centrally, and one inferiorly in the bicep groove. A Houston suture passer can then be used for placement and passage of the sutures. Typically, the superior and inferior hole are loaded with number 2 braided suture, and the central hole is filled with 2 number 2 tapes. The sutures should be passed prior to placement of the final body of the actual implant. Once the cut surface has been fully irrigated, the implant is open and passed to the field. It is next impacted down. Graft at this point can be utilized to further enhance the fixation if necessary. It is seated down and initially left slightly proud to allow for engagement of the neck within the taper of the body. The head had been assembled with the neck segment on the back table and is now passed to the operative field. It is positioned and final impaction is now carried out. Care should be made not to over-impact, especially in softer bone. Final verification of proper seating is now confirmed. Bone graft from the head again can be impacted into the bed of the osteotomy to further help with repair. Final trialing is now performed with confirmation of the previous trialed components. At this point, the sutures are now separated to begin and facilitate LTO repair. As noted, the fragment should key in into the cleft of the osteotomy site. Medial sutures are now retrieved and passed along the bone tendon interface of the subscap and lesser tuberosity. Sutures are typically passed in a similar fashion as from proximal to distal as placed in the bicep groove holes. Once again, the tapes are typically placed centrally along the better substance of the tendon and bony fragment. Once all the sutures are passed, they are individually tied by maintaining traction and reduction and trying to tie the knot within the groove to avoid for any prominence along the ventral surface of the subscap tendon. The repair is then completed by placement of a figure of 8 number 2 suture in the lateral aspect of the rotator interval. This greatly increases the strength of the osteotomy repair. Final trialing is then performed with palpation of the nerve to assure no entrapment, and once again final check of range of motion. Postoperatively, the patient will be immobilized in a sling and abduction pillow. Range of motion will usually begin typically 2 weeks once the wound is completely healed, starting with passive range of motion first. Radiographs will be obtained at 2 and 6 weeks, with the axillary x-ray typically at 6 weeks to confirm complete repair and reduction of the osteotomy fragment. I would like to thank you for your time.